Soaring high and making difference. Where we talk anything about nursing. So let your voice be heard. Right here. Moments with Professor X.
Good evening, Vegas, and good morning, Philippines. How's everybody? Today is actually Thursday, July 10, 2025. And yun nga, no, good morning, Philippines. My God. Actually, I already did the Facebook Live a while ago before I went to the movie theater because I watched a movie, Superman. Talk about that in a bit. And I decided to redo the discussion because I noticed that the audio quality is really bad. It's terrible. And may mga instances po na puputol siya at saka hindi nag-flash ng maayos yung aking animation. Anyway, to start, hello and thanks for watching to Pinky Salazar. Hi there. And hello to Pauline Bernadette. Thanks for watching. So this is for this clip, for this Facebook Live, we will talk about COPD and things to remember if you're planning to take any qualifying examination that has something to do with your COPD concept. Okay, hold on. Give me like a few seconds. I have to make sure that I'm also streaming to a different platform. Again. I'm supposed to stream sa Instagram, but my software is not allowing me to connect to Instagram, so too bad. Anyway, let's move on. Okay, so we'll talk about, yun nga, no, I watched the movie Superman. And personally, I still like the previous Superman. Sino nga yung actor niya? Henry yung pangalan niya, I forgot the family name, but mas gusto ko siya. Mas gusto ko yung movie na yun. Yung current na Superman, out of 10, 10 is the highest score. I will give it a rating na 8 out of 10. In all fairness. Pero mas gusto ko pa rin yung previous na Superman. Anyway, so we'll talk about COPD this time. So let me share my screen and let's go from there. There. Oh. Hello and thanks for watching Sandy Reyes Maville. Thanks for watching. And to Jessa Ann. Thanks for watching. Anybody who is planning to take the Nclex Rn or the Nclex PN? Well, actually, most of my students are Nclex Rn. So anybody who has a specific date for your examination anytime soon? So good luck. Now, hopefully what I am doing here for the past few years and for the past few months will be very helpful if you're planning to take any nursing qualifying exam. And hello to Jay Love. Thanks for watching. Oh, and hello to Darish Banyares Hernandez. Thanks for watching. Who is this? Darish? Darish Banyares. Who is this? Oh, I know. Dimple, my cousin. Hello. Kumusta na? How are you there in the Philippines? When are you coming back? I thought you're coming back here. Hopefully next summer or next what do you call this? Next Christmas, you can join and celebrate with us. Speaking of Christmas, few months from now, it's September. For those of you guys na hindi alam, Filipinos, we love to celebrate Christmas as early as September. Another thing, hello to Ren Bertulfo. Thanks for watching, Ren. How are you? Where are you from? Okay, let's move forward. So we'll talk about COPD this time, okay? I hope you can read my penmanship, COPD. Okay, now what does COPD stand for? Your COPD stands for chronic obstructive pulmonary disease. Okay, now it's an old name. There's a new name for this, and they love to call this now as CAL. Your CAL. CAL or CAL stands for chronic airflow limitation. Okay, so what is this type of pulmonary issue? Now, this is a type of a pulmonary disease wherein there is difficulty of air to move out from the lungs. Okay, it means to say the air is trapped inside the lungs and the air is having a hard time to get out from the body, to get out from the lungs. So technically, when you say COPD, it is a disease, a problem characterized as an expiratory, okay, an expiratory disease. More on problem with or difficulty with moving air out. There's also another disease. It's the opposite, wherein there is difficulty of air to get inside the lungs or difficulty of the lungs to expand. Now, you call that as your restrictive lung disease, which is the opposite of your COPD. But anyway, now when you talk about COPD, I can have another session for that, wherein we will talk about restrictive lung diseases. Anyway, for this clip, we'll talk about COPD. Okay. Now, what is the most common risk factor attributed to COPD? Okay. The most common factor attributed to COPD is actually smoking. Ayan. For those who smoke, you know who you are. Okay. Now, smoking is a big thing that is related to COPD. That is why, having said that, smoking is another common question in your examination. Okay. The common question here, uh, for example, number one, a common question about smoking. You are the nurse, and you are the nurse taking good care of a patient in a smoking rehabilitation program. Okay, again, patient is in a smoking rehab program. What must be the first question to ask? Okay, so again, patient is in a smoking rehab program. You are the nurse. What must be your first question? Okay, option number one, why do you smoke? Number two, on what age you started smoking? Number three, how many sticks per day? And number four, how do you see yourself when you smoke? Okay, just a recap. These are four options. Okay, uh, you patient is in a smoking rehab program, and you are the nurse. And what must be your first question to ask? First option: why do you smoke? Two, on what age you started smoking? Three, how many sticks per day? Number four, how do you see yourself when you smoke? If you choose option number one, why do you smoke? That's incorrect. Remember, never start your question with why. It's more on, it's non-therapeutic. It's judgmental question. Okay, it's not good. So let's eliminate question number one. Not question number one. Let's eliminate option number one. Number two, on what age you started smoking? It's a legit question, right? Two, how many sticks per day? It's also a right question. And number four, how do you see yourself when you smoke? So these are three possible answers, but the question is asking you what must be the first question to ask. The correct answer there is number four. And what is number four option? Number four option is, how do you see yourself when you smoke? Now, what made this option correct? Remember, your patient is in a smoking rehab program. That is why if you are in a smoking rehab program, the first question must be directed to perception of own's behavior. Okay, so do not forget that the first question is always directed to patient's perception of his or her own action, his or her own behavior. So if you ask that question to your patient, how do you see yourself when you smoke? And the patient tells you, or the patient responded, well, if I smoke, I feel that I am relaxed. So you know that the reason why patient smokes is for relaxation technique or relaxation purposes. So that will be the focus of your rehabilitation program, to teach the patient other ways of relaxation to help the patient quit smoking. Okay, I hope that makes sense. So the first question to ask if your patient is in a smoking rehab program or in any rehab program is perception of own's behavior. Okay. Number two, another common question in your NCLEX that has something to do with smoking. How do you convince a patient to quit smoking? Okay. Maybe you have relatives or a good friend and you've been pushing the person to quit smoking. You've been encouraging the person to quit smoking. What's your approach? So this is a common question in your exam. And the following options are: number one, have another smoker convince the patient to quit smoking. B, show pictures of complications associated to smoking. Or three, tell your patient of the consequences of his or her actions. Or D, enroll the patient to a smoking rehab program. Again, how do you convince the patient to quit smoking? What is the most effective way to convince the patient to quit smoking? Have another smoker convince the patient to quit smoking. Analyze. Do you think they will quit smoking? No, they will have smoking party. Okay? They will not quit smoking. So number one is out. Okay, it's eliminated. You still have options two, three, and four. Two, show pictures of complication. What is that? Is it a visual stimuli or a verbal stimuli? It's a visual because you're showing pictures. Number three, tell your patient of the consequences of his or her actions or behavior. What is that? It's more on verbal stimuli. And number four, enroll your patient to smoking rehab program. And that is incorrect. Why is number four incorrect? Because it must be voluntary. Okay. So to make it more effective and to have a more positive outcome with a rehab program, it must be voluntary in nature. So we will eliminate option number four. So we are left with option two and three. Again, two, visual stimuli. Three, verbal stimuli. Which one is better? The correct answer is two, visual stimuli. Show pictures. Okay, so do not forget that. Anyway, who else do we have here? Jessa Ann said, hello, Professor. I will take Nclex Rn examinations. And oh, when will that be? And big shout out to Hazel Nas de Los Santos for watching. And hello to my cousin, Dr. Anthony Pascasio. Hi. And hello to Clang Clang. Okay, so that's it. Now, there are things you need to remember about COPD for your exam. Okay, and what are those? I put an asterisk here. Let's put things to remember. Now, they love to ask about positioning patient. Now, what do you think is the best position for patient with COPD? What is the best position? Now, I will give you two possible answers. Okay, best position. The first answer and the second answer. The first answer is always the best answer. And what is that? Remember, if your patient is having shortness of breath or having respiratory difficulty and the patient is a COPD, the best position is orthopnic position. Don't forget that. Now, how do you describe orthopnic position? When you say orthopnic, it means to say patient is sitting upright, leaning forward. Okay, sitting upright, leaning forward. Sometimes they will add arms of the patient elevated or rested. Okay, where armrest or armchair. Okay, like that. Okay. Now, in the event that you cannot find orthopnic position, the second best position for patient, very good, Chris Furio. Congratulations, orthopnic position. Very good. In the event that you cannot find orthopnic position, the second best answer is position the patient upright. Okay, upright. Sometimes they don't use the word upright or the term upright. They may use semi-Fowler's to Fowler's position. Okay, but in the event you will see these two options, orthopnic and upright, you choose orthopnic as the first answer. Okay, next, number two. Another thing to remember when you talk about COPD. Now, if your patient is a COPD, what do you think is their primary stimuli for respiration? What is their primary stimuli to breathe? Respiration. Now, take note, I'm asking about COPD patient. Let's identify first. For normal people, normal person, what stimulates us to breathe? What stimulates us? Hey, you need to inhale, you need to exhale, you need to breathe. Okay, correct answer is hypoxia. So they're not hypoxia, but hypercapnia. Correct. I want to correct myself. Hypercapnia. If there's too much carbon dioxide in the body, that's hypercapnia. It stimulates us to breathe. But for patient with COPD, their stimuli to breathe is different. For patient with COPD, their stimuli to breathe is low oxygen. We call this as your hypoxic drive. Okay, so don't forget this. For a normal person with no COPD, the stimuli to breathe is hypercapnia or too much carbon dioxide level. But for COPD, their primary stimuli to breathe is hypoxia, or we call this as your hypoxic drive. Now, I need to stress this because patient with COPD do not give, okay, we discourage giving a high oxygen flow rate. Come to think of it, if you give too much oxygen to patient, okay, if you give too much oxygen to patient with COPD, remember, you know that their stimuli to breathe is hypoxia. So when you give too much oxygen, it causes respiratory depression because nobody now stimulates the patient to breathe. Okay, so that is why if it's a COPD, always give a low oxygen flow rate. Not only that, if a patient is a premature newborn, okay, a premature newborn, you're not supposed to give too much oxygen to a premature newborn as well. Why? Study shows that if you give too much oxygen to newborn that is premature, it causes blindness. Okay, and that blindness is related to oxygen toxicity. Okay, and you call that blindness as your retrolental fibroplasia. Okay, next, another thing to remember. Number three, since I mentioned O2 supplementation, what do you think is the best interface? Okay, what is the best oxygen device or best oxygen interface to use for patient with COPD? What is the first answer and the second answer in your exam? Remember, find an oxygen device that can deliver the most precise or the most accurate oxygen concentration. And what is that? Venturi mask. Okay, don't forget this in your exam. Venturi mask is the device or oxygen interface that can deliver the most accurate, okay, or the most precise oxygen. Okay, Venturi mask. In the event that you cannot find Venturi mask, the second answer is your nasal cannula. Okay, now highlight in your exam cannula. Now, highlight in your exam. If your patient is receiving oxygen via mask, regardless whether it's a Venturi mask or a simple face mask or an oxy mask, as long as it's a mask, oxygen mask, it increases client's anxiety. That is why be mindful if your patient is known to be what? Claustrophobic. Because if your patient is claustrophobic and you use mask, oxy mask, or whatever interface that has mask, that is mask, yeah, I think I made the right statement. Any interface, okay, that is a mask, okay, it could be Venturi mask or simple face mask. It increases client's anxiety. Not only that, a mask also increases the risk of aspiration compared to your nasal cannula. Where it's more patient can move freely. Okay, now these are things you need to remember. Okay. Now, when I say COPD, there are two common types of COPD that you need to remember in your exam. First is your emphysema, and number two is your bronchitis. So we will talk about emphysema, bronchitis. Which one is blue bloaters? Which one here is your pink puffers? And of course, I will incorporate common questions in your exam. Okay. Now, what I'm going to do here is I am going to divide the screen into two sides. Okay, what's going on? Divide the screen into two sides. On your left side, we will talk about their emphysema. Right side, we'll talk about bronchitis. Hey, Chris, how are you? Nasaan ka na ngayon, Chris? Okay, so what is emphysema? Emphysema is a type of COPD wherein there is loss of lung elasticity. So it's a COPD characterized by loss of lung elasticity. So if there's loss of lung elasticity, remember we know that when we inhale, the lungs inflate, the lungs deflate. Okay, so if there is loss of elasticity, it will affect inflation and deflation processes. Okay, and we know for the fact that alveoli is the site for gas exchange. So if you will be asked in your exam about emphysema and the question, what is the most appropriate nursing diagnosis? What do you think is the best answer in your exam? Okay, what do you think is the most appropriate nursing diagnosis for emphysema? Answer is impaired gas exchange. Please do not forget this. Okay. Why do we have impaired gas exchange? Because in emphysema, there is loss of elasticity affecting the alveoli. The alveoli will not deflate well. Remember, that is the site of gas exchange. Now, to make it more clear, now let's say that this is your alveoli. Okay. And this is your blood vessel, the pulmonary vessel. To be specific, it's capillary. Now remember, the blood inside this blood vessel is a blood rich in carbon dioxide. Okay, rich in carbon dioxide. Now when you inhale, air enters the alveoli, and that air is rich in oxygen. As a result, the alveoli inflates. Now, what happens is that when alveoli inflates, it touches, okay, it touches the membrane of the capillary. As a result, when these two membranes touch each other, that will be a good site for gas exchange. So there will be exchange of gases, specifically oxygen enters the bloodstream in exchange with your carbon dioxide. The principle behind this gas exchange is the principle called diffusion. If you can still remember that. Remember diffusion, there's movement of molecules from a higher to a lower concentration. So technically, when you say gas exchange, it's not the entire alveoli responsible for gas exchange, not the entire alveoli, just part where it adheres closely to your membrane, capillary. Okay, so come to think of it, in emphysema, if there's loss of elasticity, it affects gas exchange. That is why the most appropriate diagnosis is impaired gas exchange, because sometimes you'll be given options like altered tissue perfusion, impaired gas exchange, ineffective breathing pattern, or ineffective airway clearance. So for emphysema, again, it's impaired gas exchange. Okay. Now, what about for bronchitis? What is bronchitis? Remember, the moment you encounter the suffix itis, itis refers to inflammation. So we know that bronchitis is inflammation of the bronchial area. Okay. So why did the patient end up having inflammatory condition in the bronchial area? It's related to irritation. Okay. So bronchitis refers to inflammation of the bronchial area, may be related to inhalation of a noxious fume, or it's a smoke, or another one good example is if you get inside a room that is newly painted, so you will inhale the fume, it may also cause bronchitis. Okay, but technically the problem here is inflammation. So there is inflammation of the bronchial area. And we know that bronchial area, the bronchus, the bronchial area, it's an airway. So what will happen if there is inflammation in the airway? It narrows the opening, correct? So if it narrows the opening, it causes obstruction in the airflow. So what is the most appropriate diagnosis here? Since there is airway obstruction, correct answer here will be ineffective airway clearance. Why? Because of airway obstruction. Okay, do not forget that. And by the way, hello and thanks for watching Christy Jane Peñalosa. And of course, to Richard Navarro. Hey, how are you? What's the latest? What's the update? Tell me. So these are common questions in your exam. Now, what I want to focus here are pathologic changes. So tell me, what are common changes or pathologic changes for patient with emphysema and patient with bronchitis? Let's begin with emphysema. Number one, remember I said in emphysema there is loss of elasticity. As a result, because of loss of elasticity, there will be trapping of air inside, okay? Because it will not inflate, it will not deflate well. So second pathologic changes for emphysema will be small air trappings and or collapse. Third pathologic problem for patient with emphysema is that, okay, patient with emphysema will have hyperinflation of lung tissue. Hyperinflation of lung tissue. Why do we have hyperinflation? Because again, because of loss of elasticity, it will not deflate well. Okay, hyperinflation. Now, how will you know that there is hyperinflation of lung tissue? If you do chest x-ray, if doctors order chest x-ray, there's a specific result in your x-ray that would reflect hyperinflation. And what is that? Patient will have barrel chest. Barrel chest result. In your NCLEX, sometimes they don't use the term barrel chest. What they do is they describe barrel chest. And what is the description for barrel chest? There is increased anterior posterior diameter, increased AP diameter. Now, what is this AP diameter? If you measure from anterior to your posterior, you measure the distance, that's your AP diameter. Now, ideally, what is the normal result? What's the parameter? Your AP diameter is half of your transverse diameter. Now, what is your transverse diameter from here going this side? So if you measure that, that is your transverse diameter. So if you divide it into two, whatever is the quotient, that's your AP. So what happens? What happens in your barrel chest is your AP diameter is higher with respect to your transverse. And another thing, when you do percussion for patient with hyperinflation of lung tissue, you will get hyperresonance. 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 Why? Because of hyperinflation of lung tissue. Next, number four. Now, remember, in your emphysema, there is loss of elasticity. So it affects deflation. It affects movement of air out. So the question there, will it affect coughing reflex? Yes, because in coughing reflex, to make it effective, there is sufficient pressure and release of air out. Okay, so what happens in emphysema is that you will end up having ineffective coughing reflex. So if you have ineffective coughing reflex, and we know for the fact that coughing is a reflex that clears lower respiratory tract, you cannot clear effectively your lower respiratory, will that increase the risk of infection? Yes. That is why, don't forget this, patient with emphysema has higher risk of pulmonary infection. Don't forget this in your exam. Okay. Now, what about for patient with bronchitis? Look, Now, let's say that this is the bronchial area of your patient. Okay, it's the bronchial area. So you have here your hair-like structure. You call that as your cilia. And then you have cells underneath. You call these cells as your goblet cells. Your goblet cells are cells responsible in producing mucus. Remember, I said that in your bronchitis, there's inflammation because of an irritation. Okay. Now, so what happens is that because of an irritation, it stimulates the goblet cells to produce mucus. So the more mucus is being produced there, it will trap the normal movement of your cilia. Remember, your cilia or hair like structures, they will serve as protection. But because of too much mucus or phlegm, it traps the cilia, impairing the normal ciliary movement. So what will happen? Mucus will accumulate. Okay, mucus will accumulate, and because of irritation, there will be inflammatory process leading to airway obstruction, causing ineffective airway clearance. And take note that mucus is a good breeding site for the microorganism. So again, it will also increase the risk of infection. Okay, so let's run down. So what are common changes or pathologic changes for patient with bronchitis? Since we're done with your emphysema, let's talk about bronchitis. Number one, I said there is inflammation. Number two, in bronchitis, there will be increase in your mucus production. Excessive mucus will impair the normal ciliary movement. Okay. So number three, you will have impaired ciliary movement. And because of inflammation and mucus buildup, mucus plug formation, it causes airway obstruction. Not only that, too much mucus is a good site for microorganism. So again, it increases the risk of infection. So don't forget this. All COPD patient, okay, COPD, emphysema, bronchitis, they are prone, okay, high risk for infection. Okay, so these are things to remember, okay, about COPD. Okay, and I think I have an animation here. Hold on. This one. Swap this. I don't know if you can see the cursor moving. On the left side is your emphysema. On the right side is your bronchitis. Okay, take note. I said emphysema, it affects the alveoli, and alveoli is the primary site for gas exchange. So in your emphysema, if you look at your animation in emphysema, it affects gas exchange because alveoli is the site for gas exchange. Remember, that's where oxygen and carbon dioxide, okay, happens, exchange or diffusion happens. So the emphysema, loss of elasticity will result to impaired gas exchange. For patient with bronchitis, it's different. In bronchitis, there is airway obstruction. Now look, in bronchitis, because of an irritation, it stimulates goblet cells to produce more mucus. So excessive mucus production, what will happen is that it impairs normal ciliary movement. These are your cilia. And then because of that, mucus buildup plus inflammatory processes, will result to airway obstruction. So that's your bronchitis. So there is narrowing of airway. Now, look, having said that there's airway obstruction, you try to analyze. If a patient has an inflammatory problem or inflammatory process, what do you think is the medication that will be given to your patient? Of course, doctors will prescribe anti-inflammatory medicine, correct? Because of increased mucus production, doctors will also prescribe some medicine that will decrease mucus production. By the way, where is that? I'm looking. Wait, where is that? Hey, where's? I'm looking for my. Don't say. Where is it? Stop sharing. I need to. There. Sorry, I need to share my screen again. I lost my monitor. There. By the way, if you have any questions, please let me know. Drop a message or any question. Okay, let's go back. Because of inflammatory process, I said doctors may prescribe anti-inflammatory. So in your NCLEX exam, there are different types of anti-inflammatory medicine. Okay, so doctors may prescribe steroids, doctors may prescribe NSAIDs or non-steroidal anti-inflammatory drugs. So just don't forget, if it's an NSAIDs, NSAIDs can cause nephrotoxicity. Okay, and NSAIDs are considered gastric irritants as well. So that is why you have to take this with meal or take this with full stomach. So what are examples of our NSAIDs? So I also give mnemonics for NSAIDs as NSAIDs. N as naproxen, S your salicylates, A are coxa or arthrotec, another NSAID. I is your ibuprofen, D is your diclofenac, and S for your sulindac. So those are common NSAIDs. Just don't forget, NSAIDs are gastric irritants and nephrotoxics. Now, if you're taking steroids, you cannot take steroids for a long period of time. Steroids will decrease your immune response. That is why you have to watch out for infection. Steroids will also increase your blood sugar level. Your steroids will also, what else? Uh, it may also increase the risk of hormonal imbalances. Common there is your adrenal hormones, giving you a condition called Cushing syndrome. You cannot stop steroids abruptly. It needs to be tapered. Okay? It needs to be tapered because the moment you stop steroids abruptly, it may cause adrenal insufficiency. Okay. Thing to remember about steroids. Sometimes patient with pulmonary issue, they give steroids, they may give bronchodilator. So the question in your examination, what will you give first? Will you give steroids first, then bronchodilator, or bronchodilator first, then steroids? What do you think is the correct answer? Okay, the correct answer here is you give bronchodilator first, then after bronchodilator, that's the time you give steroids. Remember, your bronchodilator will dilate the airway of your patient. So once the airway is dilated, it's open, then that's the time you give steroids so the steroids can get inside. Okay, so open the airway first before giving your steroids. Okay, now I told you about giving medication that will decrease mucus production or will help liquefy mucus, just like your mucolytic. Okay, because of infection, doctors may prescribe antibiotic. Because of airway obstruction, doctors may prescribe bronchodilators. Now, highlight in your exam. If your patient is getting or receiving bronchodilators, there are different types of bronchodilators. Okay, we have your sympathomimetic, your xanthine derivatives. Now, if your patient takes sympathomimetic as a bronchodilator, don't forget it causes tachycardia, it causes nervousness, it causes insomnia. So don't forget that in your exam. Be mindful if your patient is an elderly and receiving bronchodilator. If a patient has an existing cardiac issue, it may cause chest pain. Okay, so be mindful when you give, okay, bronchodilator to patient. Now, sometimes we give bronchodilator not because we want to dilate the airway of your patient, but if you want to correct electrolyte imbalance, just like your potassium. One common bronchodilator given to patient is your albuterol. Okay. Now, the reason why we give albuterol to your patient here is to help decrease the blood potassium level. So we can give albuterol to patient with hyperkalemia. Now, how can albuterol help decrease potassium level in the blood? Remember that potassium is an intracellular electrolyte. Okay, to be specific, it's a cation. It means to say it's a positively charged electrolyte. Now, during hyperkalemia, there's too much potassium ions in the bloodstream. So when you give albuterol to patient, that albuterol will help move potassium from the blood into the cell. So that is why it will help decrease potassium level in the blood. Okay, that's your albuterol. But of course, there are also other ways to uh, help correct hyperkalemia. Okay. Anyway, that will be for a different concept. Anyway, who do we have here? Hello to Amanda De Vera Roy. Thanks for watching. Okay. Now, what else? So if you notice, for patient with pulmonary issue, we don't only give one medicine. Usually, it's a combination of several agents. Okay. Now, I mentioned pink puffers and blue bloaters a while ago. So which one here is pink puffers? Which one is blue bloaters? So let's start. What about for emphysema? Is emphysema pink puffers or blue bloaters? Tell me. Is emphysema pink puffers or blue bloaters? The correct answer is pink puffers. Pink puffers. Why do we call emphysema as pink puffers? Now let's begin. Let's explain why we call it pink. It's not because that their favorite color is pink. No. The reason why we call it pink, okay, there are actually two reasons. First, and the second reason. The first reason we call it pink because there is no cyanosis. Okay, because if the patient is cyanotic, that will be blue. Okay, but the most important reason is this number two. So you put an asterisk for number two. This is the most important reason. A patient with emphysema is called pink puffers because in emphysema, okay, in emphysema there is hypercapnia. Okay, there's air trapping. There's difficulty of air to get out from the lungs because of loss of elasticity. There is increased carbon dioxide level. Remember the medical term for this is hypercapnia. So what is the result or what will be the effect if there's too much carbon dioxide? If there's too much carbon dioxide in the body, okay, in the body, if there's hypercapnia, it has a significant effects, okay, to the blood vessels in the brain, blood vessels in the peripheral area, blood vessels in the pulmonary area. So technically, if there's too much carbon dioxide, it causes cerebral vasodilation, peripheral vasodilation, pulmonary vasoconstriction. Okay. So again, just a recap. So if there's too much carbon dioxide, what will happen here is that it causes cerebral vasodilation. It causes peripheral vasodilation, but it causes pulmonary vasoconstriction. Okay? Now, focus on your peripheral vasodilation. So when the blood vessels dilate, okay, when the blood vessels dilate, blood will congest. So as blood congests, it gives you pinkish discoloration. Akala mo mestizo or mestiza yung patient. No, it's because of congestion due to hypercapnia. So that is related to vasodilation. Okay, so you will have a pinkish skin discoloration. Discoloration. So don't forget this. This happens to patient with too much carbon dioxide. So you know if there is hypocapnia, a decrease in carbon dioxide in the body, you flip the signs and symptoms. So there's hypocapnia, decreased carbon dioxide, it causes cerebral vasoconstriction, peripheral vasoconstriction, but pulmonary vasodilation. It's the opposite. That is why for patient with increased intracranial pressure, increased ICP, you need to promote hyperventilation on the first 24 hours. Why? Because when you hyperventilate, it promotes carbon dioxide loss. So that will result to hypocapnia. So when the patient is hypocapnic, the blood vessels in the peripheral area, the blood vessels in the brain will constrict. So if there's cerebral vasoconstriction, less blood enters the brain, that will help decrease intracranial pressure. Okay, but anyway, that is your hypercapnia. Next, why do we call it puffers? Why do we call it puffers? We call it puffers for two reasons. Okay, number one, it's related to smoking. So you know that when you smoke, you puff, you puff, you puff. Number two, the most important reason why we call it puffers. Again, put an asterisk. Most important reason. Remember, I said that in your emphysema, there's too much carbon dioxide. So that's the reason why you puff. Because in in your emphysema, patient will do pursed lip. What is lip? Okay, pursed lip breathing. So patient will have pursed lip breathing. So when you say pursed lip method of breathing, you will have a longer exhalation than inhalation. It's just like blowing a candle. That's first sleep method of breathing. Now, what is the significance of first sleep method of breathing? When you do that, first sleep method of breathing, it promotes carbon dioxide elimination. Remember, there's too much carbon dioxide. So what will you do? You will help eliminate carbon dioxide. So first sleep method of breathing promotes carbon dioxide elimination. Remember, it's just like blowing a candle. It will have You will have a longer exhalation than inhalation. Oh, big shout out to Ma'am Blue Ann. Hi, Ma'am Blue Ann. Okay, so that's your emphysema. Now, what about your bronchitis? Bronchitis. So, of course, no options left. So if emphysema is pink puffers, what about bronchitis? Bronchitis would be blue bloaters. Blue bloaters. Now, why do we call bronchitis as blue bloaters? Let's begin with blue. Why do we call it blue? Very timely, Ma'am Blue Ann. This is your time to shine. Blue. Why do we call it blue? We call it blue for two reasons again. Okay. We call it blue because there is cyanosis. Positive for cyanosis. Okay. We call it blue. Why do we call it blue? Oh no, sorry. There's only one reason for that. Cyanosis. Sorry. For puffers, why do we call it okay, sorry, bloaters. Why do we call it bloaters? Oh my god, what's wrong with me? You're messing it, Professor X. Why do we call it bloaters? We call it bloaters for two reasons. Okay? Why do we call it blue bloaters? We call it blue bloaters because a patient with bronchitis will end up having clubbing of fingers. Clubbing of fingers. Remember, patient with chronic bronchitis will have chronic hypoxia. Chronic hypoxia will cause clubbing of fingers. So don't forget this in your exam. There is no clubbing of fingers during acute hypoxia. Clubbing of fingers happens if the hypoxia is chronic in nature. Okay? Now, how do you check for clubbing of fingers? There's a technique that we use. If you do this, you call that a Shamroth method. Shamroth method. Okay, number two, bloaters because there is edema. Why is your patient edematous? Edema is secondary to, okay, edema is secondary to right-sided congestive heart failure, secondary to, why did I put number two? Hey, this is secondary to cor pulmonale or cor pulmonale. Okay, expound. So a patient with bronchitis is bloated because the patient is edematous. Why? Patient is edematous. It's related to heart failure. Why did the patient end up having heart failure? Because of cor pulmonale. What is cor pulmonale or cor pulmonale? Cor pulmonale or cor pulmonale refers to enlargement of the right ventricle due to pulmonary problem. That is why if the cause of cor pulmonale is pulmonary problem, to correct cor pulmonale, you have to correct or treat pulmonary problem. Okay. Now, why did it happen? Now, if you go back to your cardiovascular system, okay, this is our heart, and our heart is divided into two sides, right side and left side, divided into four chambers, right atrium, right ventricle, left atrium, left ventricle. Remember that the right atrium receives blood, okay, from your superior and inferior vena cava. Okay, that is from your systemic circulation. The right ventricle pumps blood going to your lungs. Okay, and tell me what's the condition of the patient. Patient condition is bronchitis. So there is inflammation of the bronchial area. So if there is bronchitis, what happens is that because of an inflammatory response, one effect of bronchitis is that it causes vasoconstriction. So the blood vessels in the bronchial area, the blood vessels in the pulmonary area constrict. So there's vasoconstriction. So come to think of it, the blood vessels in the lungs are constricted, all related to bronchitis. So if the blood vessels are constricted, do you think blood flow is possible? Depends on the degree of obstruction. All right. But nevertheless, because of vasoconstriction, it narrows the blood vessel wall, then you will have a hard time to push the blood to enter that specific vessel. As a result, the right ventricle will exert too much effort. The right ventricle will increase its functional demand to push the blood to enter the lungs because there is increase in the vascular resistance in the pulmonary area. So technically, what happens here is that there is an increase in the afterload, okay, on your right ventricle. Why? Because of pulmonary vasoconstriction. Because of an increase in the resistance, it increases the workload of the right ventricle. An increase in the functional demand of the muscle. Compensation of that is it will increase its size. An increase in the size of the muscle is called hypertrophy. So to be specific, you call that as right ventricular hypertrophy, enlargement of the right ventricle. Same thing if you go to the gym, if you work out very often, okay, if you lift weights very often, what happens to your muscle? They grow, they increase in size. There's hypertrophy of muscles because you work out. Remember, if you work out right now, if you lift like 20 pounds and then weeks after you lift 30 pounds, so there's increase in the weight that you lift, it increases the workload of the muscles, it increases the functional demand of the muscles. As a result, the muscles hypertrophy. As a result, the muscles increases its size. Okay, so it's a normal physiologic response to, okay, increased workload. So this will result to right ventricular enlargement. Okay, so what is the medical term for increase in the size of the right ventricle due to pulmonary problem? Cor pulmonale. Okay, now because of enlargement of the right ventricle, it stretches the tissues in the right ventricle. Okay, so if you do that for a long period of time, it affects the elasticity as well of the right ventricle. It affects the pumping ability of the right ventricle. The right ventricle now will not pump well. What is the disorder or the problem? Inability of the heart to pump well. You call that as heart failure. Okay? So if there is heart failure or inability of the heart to pump well, the blood cannot get out from the right ventricle. As a result, the blood congests in the right ventricle, filling the right ventricle, filling the right atrium as well. So, as a result, because of the failure of the heart to pump well, the blood accumulates on the right side of the heart. There is congestion, okay, on the right side of the heart. So, right sided congested heart failure, okay, develops. So, what will happen now if the right side of the heart is congested, filled with blood? Blood from the systemic circulation cannot get inside the heart because the right side of the heart is already congested. Okay, so they will stampede, they cannot get inside. So, therefore, blood cannot get inside the heart, blood accumulates in the systemic circulation, giving you now systemic congestion. And if there is systemic congestion, it leads to edema formation. Okay, so basically, the patient here is edematous. Edema is a manifestation of right-sided heart failure. Patient end up having heart failure because of cor pulmonale. Why did the patient end up having cor pulmonale? Because of COPD, and that is a question in NCLEX. Sometimes they will ask you, "Wait, what specific COPD will most likely cause heart failure?" So between emphysema and bronchitis, which one will most likely cause heart failure? The answer is bronchitis. And what type of heart failure? Answer, it is right-sided heart failure, not left. And take note, if it is right-sided heart failure, you will have systemic congestion, systemic manifestations. Okay, I hope that one is clear. There we go. Oh my God, finally I did that. I did it again, okay? Redo the discussion. Anyway, I hope you learned something, guys. Who do we have here? Thanks for watching, Christy Jane, Peñalosa, Waminal. Thanks for watching. Okay, here Richard Navarro said, currently working on my docs for Canada and US. Oh, that's good. Okay, I think that's all for tonight. Thank you so much, guys. I hope you learned something. So keep safe. God bless. And I hope to see you soon. Bye.